Hi everyone, I'm Dr. Sagar Sahu and welcome to Vet Surgery at Edge. So first of all, there are some announcements, actually three announcements. So first one is I have deleted the Telegram channel, okay, because I am really busy maintaining between the job, home and passion. So it is very difficult to manage all those social media handles. So I have deleted the Telegram, but all those things which are done in Telegram will be done in Instagram. Okay, so do follow me there. Second, all the lecture videos that I have uploaded in the series, the general surgery, the veterinary anesthesiology, canine diseases, bovine disease, and this series, the diagnostic radiology, I have updated the link to particular lecture. Okay, if you want notes, PPTs or books referred for that lecture, you can go to that lecture and check the description. I have given the drive link where you can view and download the notes for that particular lecture. Okay. Third, do follow me in Instagram. That will be the only one-stop solution to all the queries of yours, and also I post all the lecture notes, especially my notes, my handwritten notes, in that particular page, that is at the Vet Essentials. Okay, so you can follow me there. You will get notes update, also the videos which will be coming, I will give the update there only. Okay, so these are the announcement. Let us go back to our video. So today we will be dealing with the radiography pathology of the diaphragm. As you know, we are doing the radiography pathology of different organs of abdomen and thorax. I have already completed the abdomen. This is the 12th lecture actually. We are continuing the radiography pathology of the thorax. We have already completed the larynx, trachea and esophagus. I will give the link in the description. Do watch those videos. Today we will be dealing with the diaphragm. So this is the book which I am referring. You know it, the Veterinary Diagnostic Radiology by Donald Litton. Very good book. If you want some knowledge beyond this class, you can follow this book. Okay, so let us go to some anatomy first, because radiology is all about anatomy. Entire surgery is all about anatomy. So first of all, this is the diaphragm. It originates from the xiphoid cartilage. This is ventral surface. This is the dorsal surface. This one is the left, and this one is the right. Okay, so it originates from the xiphoid cartilage and inserts at the level of L2, body of L2 and the L3, the cranial portion of L3. This is the insertion point of the crurus. Okay, so it contains a central tendinous portion. This is the tendinous portion, this portion is the tendinous portion, and this peripheral muscular portion. It contains three muscles: pars lumbaris, pars costalis and pars sternalis. So these are basically muscles. Most of the diaphragmatic hernias in the diaphragm radiography pathology will mostly dealing with the hernias. So most hernias occurs in this muscular portion rather than the tendinous portion. The diaphragm has three openings. The dorsal one is the opening for the aorta, and the central one is the opening for the esophagus. Towards the right side, this is the opening for caudal vena cava. So these three openings of diaphragm. Okay, you should know this. Okay, because sometimes differentiating between the right and left lateral views. Okay, differentiating factor will be this caudal vena cava opening. Okay, it joins to the right side towards the right cross. Okay, so it will be helpful. This is the anatomy. Just remember that most of the diaphragmatic hernias occurs at the muscular portion, okay, rather than the tendinous portion. We will deal with the diseases where we will see the radiographs. This is surface radiograph. This view is left lateral. This view is right lateral. I have discussed vividly regarding the differentiation between the left lateral and the right lateral view, how to differentiate it. When you don't know which one is the right lateral and left lateral, you can watch that video. I will keep the link in the description. Okay, that is the normal thoracic interpretation, thoracic radiograph interpretation. So let us see from things. Left lateral. In left lateral, see, there are some basic principles. Okay, first one is the dependent crura. The dependent crura will always be cranial. The dependent crura. Okay, like here, this is left lateral, so dependent side will be left side. So dependent crura is left crura. So this is left crura and this is right crura. Similarly, this is right lateral. The right hand side will be dependent side. So the cranial will be the right crura and the caudal will be left crura. Second, you will find the fundus of the stomach attached to the left crura. So here you can see that this is left crura and here is the stomach. Okay, stomach will be attached to the left crura. Here you can also see this is the stomach which is attaching to left crura. Third thing is the caudal vena cava. So the caudal vena cava will be joining to the right crura. Radiographically it will be joining to right crura. Okay, these are also the differentiating factor between the left lateral and the right lateral. So here you can see this caudal vena cava, it crosses the left crura and joins to the right crura. Okay, similarly right lateral, it is joins directly to the right crura which is cranial. So these are the basic differentiating factors between the left lateral and the right lateral. There are other factors also I have discussed in the interpretation of thorax. Okay. Another thing you should remember, you see the Hiatal or the border of heart and the diaphragm will be clearly visible. Okay, when there will be diaphragmatic hernia, this visibility will lost. The first thing. Okay, so we have to remember that the Hiatal, or you can say the caudal border of caudal margin of heart and the thoracic margin. Now the diaphragm will be have a abdominal margin and thoracic margin. Abdominal margin is not very clearly visible because of liver near the soft tissue opacity, but the thoracic margin is very clearly visible because of lungs, which is air filled, which provides the contrast. Okay, so these things will be very clearly visible. Here you can see, okay, this is the caudal margin of heart and here is the diaphragm. Okay, this is the diaphragm. These are two cruras. Another thing, the cruras will be diverged away in left lateral view and it will have a parallel appearance, almost run parallel in right lateral view. These are also differentiating features. But remember thing, these differentiating features will only be visible in medium size and large breed dogs. Medium breed and large size breed dogs. Okay, but these features will not be visible or it is not appreciated in case of cats and small dogs. Okay, small breed dogs. So it is very normal if you are not finding this kind of differentiating features between the left lateral and the right lateral. Next is the ventrodorsal and the dorsoventral. This is the ventrodorsal view, VD view. This is DB view. So the differentiating feature is in VD view we will find three structures. One is the cupula, this is the cupula, and these are two cruras. This one is the left crura, this one is the right crura. While in case of DB view, we will find a single dome, which is basically the cupula. Same thing, it will only visible. Sometimes you may not find the one crura or one crura will be absent in VD view also. So you don't need to worry, but normally they will find all three structures, and in dorsoventrally you will find one dome. Okay, three domes versus one dome. Sometimes you may find two domes also. It is normal. Similarly, like the previous one, it is only visible or only consistently found in case of large and medium breed dogs, not in small breed dogs and cats. Let us see some cats. Let us see some other structures, other radiographs. This is right lateral, this is left lateral. Okay, so you can see here, okay, this is right crura, this is left crura. Okay, you can see the fundus attaching to the left crura. You can see the margin of heart, caudal margin of heart clearly visible, and also diaphragm is clearly visible. Usually diaphragm originates from the xiphoid cartilage, okay, and it inserts at the level of L2, L3, body of L2 and the cranial ventral margin of L3. But radiographically, the intersection point of diaphragm and the vertebrae are usually between T11 to T13, normal. But it can vary in normal cases also from T9 to L1. Okay, remember this one. Now, you can see the border here. This is the left lateral view. You can see the diverging of the crurage and the stomach attached to the left crura. This is left, this is right crura, and you can also see the margins of the heart and the diaphragm very clear. Okay, thoracic margin. This is thoracic margin of diaphragm. This is the abdominal margin. Abdominal margin is not that clear because of soft tissue opacity caused by liver, while it is very clear the thoracic portion because of presence of lungs. Okay, now we understood the diaphragm anatomy and how they normally appear. Okay, then you can appreciate the pathology. This is VD and DB view. Similarly here you can see this is DB, it has a single dome. This is VD view. You can see one crura only. Okay, this is the right crura. Left crura is not that visible. Oh, here is right visible. Okay, so this is 3 domes. This is 1 dome. BD versus DB view. It's only in large and medium breed dogs, not in small breed or cats. This is a cat. You can see the crurage. Okay, in both cases it is not that diagnostic, or you can say differentiated. You can, both in cases you will find 2 crurages, but not that differentiating. This is left lateral, this is right lateral. Although you can say that in left lateral there is slightly more divergent, and in case of right lateral it is not that divergent, but it is not a consistent finding like in case of dogs. Okay, so this is cupula. Here this is cupula. Okay, this is heart, caudal margin of heart. This caudal margin of heart, which are separate and clearly visible. Okay, in case of diaphragmatic hernia, this visibility will be lost. We will see that. This is cat. In case of cat, I told you, and also small bits, you will find a single dome rather than 3 domes in ventrodorsal view. This is BD view. There is a ventrodorsal view. You will find a single dome, that is cupula. Now, the radiographic signs of disease. Okay, these are basically differentiating diseases. Let us see. So, in the diaphragm, it may change the shape, it may change the size, and it may change the location. So, based on that, there are some diseases which you can diagnose or you can differentiate. The first one is the surface outline. Loss of the surface outline, especially the thoracic one, thoracic surface outline. This outline. Okay, this is the thoracic outline of the diaphragm. Okay, here you can see only 1 cupula and 1 crura is visible. Okay, rather than the 2 crura and a cupula, that is 3 domes. Here only 2 domes, that is also normal. So in case of, if it is generalized, okay, entire diaphragm, it may be bilateral pleural feed. We will discuss the pleura also. After this we will discuss the mediastinum, then after we will discuss the pleura. So what happens if there will be accumulation of pleural fluid? Okay, if just like this, if there is accumulation of pleural fluid, then the thoracic margin, okay, like this, the pleural accumulation happens like this. In pleural accumulation, the lungs lobes will be visible very clearly. They will float. Okay, those are things we'll see. Okay, but just imagine if these will become soft tissue opacity. When there will be fluid, it will become soft tissue opacity. So this visibility of the thorax, or the thoracic surface of the diaphragm will be lost. But it is not a disease of diaphragm, it is more a disease of thorax. Okay, so one thing, next, caudal long lobe disease. You know that these are caudal lobes of, this is the left caudal lobe, this is right caudal lobe. Okay, if some mass is there, or entire the lobe has been diseased, or there has been pneumonia of these lobes, okay, so then also you can see that the surface outline will be lost. Okay, next, localized. These are general condition. Localized thoracic mass, suppose there is a mass in the caudal long lobe. Okay, there is one mass here like this. So there will be focal loss of this outline. This focal loss of outline, here will be outline, clear outline, here clear outline, only this part of outline will be lost. This is also a disease of thorax, not diaphragm. Diaphragmatic hernia, this is the disease of diaphragm. We will deal with that also in coming time. So diaphragmatic hernia, sometimes they are smaller ones, where you will find this type of ball. Sometimes they are bigger ones like this. Okay, we will see photos. Focal caudal long lobe disease. Similarly, this is general disease, this is focal. It means a small region, or the only one side lobe will be affected. In that case also there will be partial loss of thoracic surface outline of diaphragm. Next is the shape change. Okay, just imagine how they will appear. You will know that how they will appear. Thoracic masses adjacent to diaphragm. Similarly, if a long lobe has small mass, here mass, okay, it may push the diaphragm to change some shape. Okay. Hiatal hernia, we'll discuss hiatal. Actually, I have discussed the hiatal hernia vividly in case of radiography pathology of the stomach, but I will show you some pictures how hiatal hernia looks. Small diaphragmatic hernia discussed just now. Then the hemiparalysis. If there will be paralysis, then the one side, hemi means one side. Okay, the diaphragm will be more flatter. Okay, so it will change the shape. Then unilateral tension pneumothorax. See, the difference between hemiparalysis and the tension pneumothorax is unilateral. In case of hemiparalysis, the diaphragm will be shifted cranially, while there will be tension pneumothorax. Due to pressure, this diaphragm will move caudally. Okay, compared to the normal one. Here will be the normal one. So that in that comparison, you can differentiate between the hemiparalysis of the diaphragm and also the unilateral tension pneumothorax. We will also discuss tension pneumothorax when we will be dealing with the pleura. Next, the displacement. First one is the obesity. When in obesity, actually the abdominal fat content increases. Due to the increase in abdominal fat content, it will push the diaphragm more cranially. Okay, this is cranial displacement. First one is cranial displacement. Peritoneal fluid, that is ascites. When there will be ascites, it will push force on the diaphragm, or in turn it will move cranially. Abdominal mass, like most prominently liver mass. If there will be liver mass, it will push the diaphragm cranially. Generalized paralysis, if the entire diaphragm is paralysis, then it will also move cranially. Caudal displacement is tension pneumothorax. In unilateral, only one side will move caudally. In bilateral tension pneumothorax, it will move caudally. Entire diaphragm will move caudally. Okay. These are the radiographic signs of disease, but all of the diseases are not the disease of diaphragm. Rather than, you can say these are basically the differentiating diseases around the diaphragm, around the change in the shape, size and the outline of the diaphragm, through which you can differentiate different diseases. Now coming to our main topic, we will mostly deal with the diaphragmatic hernia. That is the only disease you can say. There is another also disease, that is paralysis, but that is not so common. So diaphragmatic hernia. So what is diaphragmatic hernia? That is the protrusion of abdominal viscera through diaphragm into the thorax. There are different types. Traumatic, this is the most common one. All the diaphragmatic hernia, this is the constitute around 50% of all the diaphragmatic hernias. So this is traumatic hernia. Hiatal, peritoneo-pericardial. You see these two, the hiatal and the peritoneo-pericardial, I have discussed vividly in the chapter stomach. Okay, I will be showing some radiographs in this class also, but do check out the video. I will give the link in the description regarding the hiatal hernia and the peritoneo-pericardial. There is also peritoneal-pleural. It's very rare. We will be mostly discussing the traumatic diaphragmatic hernia. Now there are several techniques through which you can diagnose the diaphragmatic hernia. First one is, you know, that survey radiograph. Second, you can go for the barium sulfate, especially when the stomach is herniated. Okay, so here you can give 30% weight by volume barium sulfate and the dose rate of 0.5 ml per kg. Okay. Now horizontal beam, we will see some radiographs also. Horizontal beam radiography can help diagnose, especially when it contains the pleural fluids. When it will be containing the pleural fluids, it will be very helpful, the horizontal beam radiography. Positive contrast peritonography, here you will be infusing or you will be injecting the non-ionic iodinated contrast. Why non-ionic? Okay, if you will give non-ionic, if you will give ionic contrast, then it causes dehydration. It will suck all these fluids around the structures, that is from intestine, stomach, like that. It may cause dehydration. So preferably non-ionic iodinated contrast. Okay, iodinated contrast will be injected into the abdomen at the dose rate of 2 ml per kg. After giving, so you have to elevate the abdomen, that is the caudal side of abdomen, so that all the contrast will be accumulated at the diaphragmatic surface. Then after you can take X-ray, we will see some photographs also, radiographs also. See, this one is the survey radiograph. You can see here clearly. See, this one is the caudal margin of the heart, but this location there is border effacement between the heart and the diaphragm. Okay, this is one of the sign of diaphragmatic hernia. First, second, you can see this soft tissue opacity here. This is lateral view. This is the soft tissue opacity you can see here. So it may be some long lesion also. Okay, you may suspect. Then you have to go for DV. Okay, or VD view. You can see here in VD view. See, this is the left hand side of diaphragm. The surface outline of the right side is lost. The change of diaphragm is lost. You can see this protrusion. Okay, you can see something is protruding from diaphragm into the thorax. So it is basically diaphragmatic hernia. This is evident from the survey radiograph only. Sometimes you may not find in survey radiograph. See here, this is a right lateral view of a cat who has an accident. Okay, you can see the entire radio opacity of the thorax is slightly increased. It does not look like this. There is slight increase in opacity of the lungs in lateral view. When the ventrodorsal view was done, you can clearly see only the right hand side diaphragm is visible, the outline is visible, while the left one is not visible, and also there is increase in soft tissue opacity, or there is soft tissue opacity in one half, the right hand side half of the right thorax. Sorry, this one left. I am very sorry. So the left thorax, the half of left thorax has some soft tissue opacity. Okay, due to accidental trauma, little barium was given. So you can now clearly see the stomach has been herniated into the thorax. This is stomach. Entire stomach has been herniated into the thorax, due to which there is increase in overall opacity of the thorax. Okay, because stomach has fluid opacity depending on whether the fluid is present, or it may be gas opacity if there is gas present. But most of the time when it is herniated, it has some fluid opacity. Another technique I told you, third one is horizontal beam radiography. It is helpful especially in case of pleural effusion, if there is pleural effusion along with diaphragmatic hernia. So here you can see, I told you in case of pleural effusion you will see different lobes clearly. Can you see here? This is one lobe. I am marking one lobe. Here is another lobe. Okay, and here is another lobe. Okay, this is basically the right side. Right side are 4 lobes: the cranial, the middle, the caudal, and the intermediate. Okay, so this is very clearly visible in case of pleural effusion. Also, if you will see the lateral view, you see here the lungs. See, this is one lobe, this is another lobe, and this is another lobe. Lobes are very much clearly visible, and the lungs seems to be floating. Okay, this is also the evidence of the pleural effusion. Okay, so in this particular case there was pleural effusion, as you can clearly see, as well as you can see that the right hand side diaphragm is normal, or you can say it is visible, but the left one is not visible. There is loss of the surface outline of the diaphragm, or also the diaphragm shape has been changed. Okay, like this one. Okay, entire thing has been changed. So what happened here? Also lateral view, you can slightly see here the diaphragm, but especially this region, even the heart is not visible, the diaphragm is not visible. It is only because the pleural fluid is present. So in that particular case, the animal was kept on dorsoventral view, ventrodorsal view, and the beam has been rotated 90 degree and the X-ray was taken, so that by default gravity the fluids will be accumulated on the dorsal side. This is dorsal side, this is ventral side, and you can clearly see the heart. Here you can clearly see the cranial border. This is cranial side, this is caudal side. So you can see the cranial border of heart. Still you can't see the caudal border of heart and also the diaphragm. So it seems that there might be diaphragmatic hernia along with the pleural effusion. Many times if this is not helpful, then you can remove the pleural fluid, then after you can take another radiograph, okay, then you can identify the diaphragmatic hernia. So this is a technique, that is horizontal beam radiography. This is last technique I told you, where you have to put peritoneography, contrast, positive contrast peritoneography. So you have to inject the contrast agent and elevate the abdomen so that the contrast agent will get accumulated. You can clearly see here the accumulation of contrast agent. Okay, this is the accumulation of contrast agent suggesting diaphragmatic hernia. Okay, usually this is the last thing. Okay, the positive contrast peritoneography is the last technique. Okay, you should not apply this as soon as you don't get any from survey radiography. You have to go barium swallow or other things, different, changing the views, changing the angles, then after you have to go for these techniques. Next, the traumatic diaphragmatic hernia, which is the main disease of diaphragmatic hernia, usually involves the muscular portion, I told you, and the right hand side has slightly higher incidence than the left side. Usually they are, the article actually suggests they are nearly equal, only the right hand side has some edge. The most common organ in the order of preference: liver, small bowel, stomach, spleen and omentum. You see, small bowel and stomach are comparatively easy to diagnose because at times they contain gas and they contain fluid. Depending on the view, if you are changing some between the right and left lateral, you can diagnose the small intestine and the small stomach based on gas present. Still you can diagnose some liver because of soft tissue opacity. Spleen also have soft tissue opacity, comparatively slightly bit more difficult to diagnose, especially the which organ has been herniated. And the most difficult one is the omentum. Okay, it has fat opacity, so it is very difficult to diagnose when omentum is herniated into the thorax, especially radiographically. You can go for best technique to diagnose is CT, okay, or you can go for USG. Some cases you can go for USG, or CT image also helpful, but radiographically you can have some idea. Okay, many of the colleges may not have this CT, especially USG. Most of the colleges now have USG, ultrasonography, but CT is not present in all colleges, so radiography can give you some knowledge. Next, these are radiographic signs, these you can note down. Okay, very helpful and important. The abdominal viscera within the thorax, this is the conclusive sign. Okay, this is the conclusive sign of diaphragmatic hernia. There are some other signs: displacement of abdominal thoracic organs or both. Okay, when something will be herniated, the abdominal organs might get displaced. Okay, for that you have to take additional radiograph of the abdomen. Okay, and also when the abdominal organ will be pushing to the thorax, then thoracic organ might get displaced, or sometimes they happen both. Partial or complete loss of the thoracic surface outline. We saw some radiographs also. Thoracic surface outline is lost in case of diaphragmatic hernia. Asymmetry in case of VD, the domes is nearly symmetrical. Okay, so the symmetry is lost. Altered slope in case of lateral view. We saw some things like that. In the pleural effusion case, you can go back and see that the slope is lost. Presence of pleural fluid, it happens when there is chronic diaphragmatic hernia. Shifting of mediastinum, it happens when the thoracic organs will shift. Obviously the mediastinum will shift. We will see some radiographs and we will analyze. So this one, first one is abdominal viscera. So you can see, we have seen this radiograph actually. You can see something is there, but still you cannot diagnose that it is from the diaphragm or like that until and unless you go for VD view. Next, the displacement of organ, lateral view cannot diagnose. If you are taking the radiograph of the abdomen, then you can say that some might have displaced. Partial or complete loss of thoracic surface outline, yes, it is present here. You can see up to this portion there is loss of the thoracic surface outline of the diaphragm. Asymmetry or altered slope. Slope is not that much altered, it is slightly normal, still normal, although there is some portion is lost, but still. Presence of pleural fluid is chronic cases you will find. Shifting of mediastinum is more pronounced in VD view or DB view. Let us go to the VD or DB view. Here you can see abdominal viscera within the thorax. By this you can say that some abdominal viscera might have gone. Still these are soft tissue opacity, so it is very difficult to say which organ has gone, but at least you can say that some organ has gone. Displacement of abdominal thoracic organs. Here you can see there is no displacement of thoracic organs. If you are taking some abdominal view, then you can say that about the abdominal displacement, organ displacement. Partial or complete loss of thoracic surface outline. Yes, you can say up to this portion, particularly in this portion, there is loss of thoracic surface outline of diaphragm. Presence of pleural field, it is in chronic case. Shifting of mediastinum, in this particular case there isn't any shifting of mediastinum. It is slightly it is still present in the middle. Okay, let us see some other radiographs also. This one is another case. First one is abdominal viscera within thorax. Let us see this radiograph. Yes, it is conclusive here also. You can see that. Can you see the stomach has been herniated? Okay, due to the presence of gas in the stomach, this is the conclusive sign that this is diaphragmatic hernia. Displacement of abdominal thoracic organs or both. From lateral view, cannot say that whether this has been displaced or not. Partial or complete loss of thoracic surface. Yes, you can say up to this you can say that the diaphragm is present, but after that there is the complete loss of thoracic surface outline of diaphragm. Next, asymmetry or altered slope. Yes, slope has been altered up to this. Okay, then the slope has been altered. Presence of pleural field, it is chronic cases. Shifting of mediastinum, we will see in the VD view. This is VD view, you can see here. So this is the stomach which has been herniated, and seems that some intestinal loops is also there. Okay, so first one is conclusive. You can see the stomach has been herniated. Displacement of abdominal thoracic organs. Yes, the heart has been displaced. Okay, it has been displaced to the left side, totally to the left side. You see the heart is present in mid mediastinum. Okay, when heart is shifted, the mediastinum is also shifted. Okay, shifting of heart is a reliable sign of shifting of mediastinum. So mediastinum is also shifted. Asymmetry, you can clearly see asymmetry. In fact, the diaphragm is not at all visible, slightly visible here you can see, but most of them are not visible. Presence of pleural field is in chronic case, you may not find in every cases. This is another one, abdominal viscera within thorax. Yes, you can see here the stomach has been herniated. These structures are basically hemostatic clips. This cat has undergone previous surgeries. Okay, so for checking of bleeding, you have to apply clamps. Sometimes they are used radio opaque clamps, so which may be visible in radiography, which is not abnormal. Okay, displacement of abdominal and thoracic contents is not that visible. Here you can say that there is some fluid accumulation or pleural effusion. Okay, particularly in this region, but it is not that prominent. Partial and complete loss of the thoracic surface outline. Yes, diaphragm is not at all visible. Asymmetry or altered slope. There is no slope when the diaphragm is not visible. Presence of pleural field. Yes. Shifting of mediastinum, it is more pronounced in VD view. It is VD view. See the VD view here. You can see here some part of diaphragm is visible, especially the right side, and you can see the stomach has been herniated into the thorax. The heart has been shifted to right hand side. When the heart is shifted, it means the mediastinum is also shifted. Okay. And you can see partial loss of thoracic surface. Yes, this particular portion of diaphragm, the thoracic surface outline has been lost. Okay, so this is basically the traumatic diaphragmatic hernia. Look for these signs and you can say that whether this is diaphragmatic hernia or not, but you have to still look for the differentiating features I told you regarding the change of shape, size and the thoracic surface outline. Then keeping those things in mind, you can diagnose the diaphragmatic hernia. This is the hiatal hernia. I have discussed hiatal hernia vividly in chapter stomach. Okay, hiatal hernia is of two types majorly. One is sliding one, another one is paraesophageal. Okay, go to that class. I'll give the link in the description and you can check those things. So this in particular the sliding hernia, you will find this soft tissue opacity in the chordodorsal margin of thorax. This is chordodorsal. You can clearly see a soft tissue opacity here. Okay, this is the soft tissue opacity. This is very much characteristics of hiatal hernia. But most of the hernias are sliding hernias. So when the same animal was presented on VD view for the radiography, you can see there isn't any bulging of the diaphragm. Okay, any bulging of diaphragm. So as this is sliding hernia, the VD view is very much normal. Sometimes to do this, to find this sliding hernia or to diagnose, you have to increase the abdominal pressure. Then you can see the herniation of this, especially the fundus of the stomach. Okay, I have discussed very vividly in the class stomach, because it is mostly a disease of stomach and also a disease of diaphragm. Here is the contrast. You can clearly see this is, remember the position. Okay, this is caudodorsal, this is caudodorsal surface, caudodorsal of thoracic region. Okay, when we will discuss the mediastinum, we will see differentiation of the regions in the next class. Okay, next is peritoneo-pericardial. This is a congenital disease. Okay, this is a congenital disease, so you will find mostly in young animals, congenital disease. So here you can see there, the major thing is the cardiac silhouette or the cardiac margin will be enlarged. Cardiac silhouette will be enlarged. Here you can see the cardiac silhouette is highly enlarged. Okay, and also there is loss of this portion, especially the ventral portion. It's the thoracic surface outline of diaphragm is lost. Here simply see, this is right lateral view. Okay, when the left lateral view was taken, you can see that the stomach has been actually herniated. You can see this left lateral view, the crura is diverging, while here is nearly parallel. Okay, so when left lateral view was taken, simply changing the position sometimes can make diagnosis easier. Okay, so you can see here it is herniating into the thorax, and in DV you will see this, sorry, VD, you will see this thing has been herniated into the pericardium. You can see here. Okay, so the mediastinum has been increased, the size has been increased, and also the size of the heart. It should be differentiated from the cardiomegaly also, but the signs and symptoms will be different. In cardiomegaly it will be different, and especially in the diaphragmatic hernia or peritoneo-pericardial hernia, its signs will be different, and also it is mostly due to congenital nature. It will be found in young animals, while the cardiomegaly or such things usually they are found in geriatric patients, but it may be found in young patients also. Okay, so next is, this is another picture of peritoneo-pericardial hernia. Here the intestines, the animal has been fed with the barium. You can see the fundus of stomach. Here is the pylorus. Some portion of the small intestine has been herniated, and you can clearly see how big the cardiac silhouette is. Okay, so this is the prominent sign of peritoneo-pericardial hernia, and you can see the loss of the interface or thoracic surface outline of the diaphragm. Simply by changing the view, here it has taken right lateral. You can see the right lateral. When the left lateral view was taken, slightly diverging, you see the gas from the fundus has been entered the pylorus, then the small intestine. You can see multiple loops of intestine has been herniated into the pericardial side, increasing the pericardial or the cardiac silhouette. Okay, so this is peritoneo-pericardial hernia. And regarding peritoneo-pleural hernia, this is a very rare disease, and they look exactly same like traumatic diaphragmatic hernia. So you basically can't decide. It may be diagnosed during the surgery. So this is all about the diaphragm. Okay, radiography pathology of diaphragm. Next we will go for the mediastinum. Okay, after that pleura, then the heart or the cardiovascular system. Last class will be the of lungs. So till then, tata, bye bye, take care.